Hello everyone, my name is François Cornelis. I'm French, as you can hear, but now I'm working in New York. I was really lucky to start to implant the V-STRUT some time ago, and so we work with Cecile to conduct a multi-center pilot study on feasibility and safety of the V-STRUT implantation. So tonight I'm going to present you some of the results. So this is my disclosures. So the purpose was to prospectively evaluate the safety of V-STRUT for the treatment of vertebral compression fracture and the feasibility of this new technique. And we evaluate some outcomes, but over 1 year follow-up. So I think you are all aware of the technique, so I'm not going to go back to this, and we will probably discuss about later. So it's a prospective clinical trial over 12 months follow-up. 3 institutions were involved, all in France. One was mine at Tenon Hospital in Paris, in the center of Paris. Another was Institut Gustave Roussy, which is very close from Paris and dedicated to cancer. And the last was in Bordeaux, in the southwest of France, where we are working with a surgeon. So the parameters we were recording were the procedure duration and characteristics, the length of hospital stay, the complication, the pain, and the disability. So more or less that's the design of the study. We had several visits, and we were recording what I presented, so patient information, etc., and pain, and we also recorded some images. So this study was conducted from 2019 to 2021. The issue is we had to deal with the COVID. Which it's worldwide, but started in February 2020 in France. And so we were just able to include 9 patients, 4 men and 5 women. Median age was 59. Among these tumors, patients, we had 5 patients with tumors. 3 were osteoporotic and 1 traumatic. Most of them were A1 for the Magog classification, or A3 for 1, and only 3 patients had multivertebral compression fracture, but we only treat 1 level with the V-STRUT. So that's a summary of the location and the implant site. So location was mainly lumbar. Most of them, in fact, we didn't treat above in the thoracic spine, lower thoracic spine. Mainly L4, but L3, L4. For these procedures, we were using mainly the small implant of 5.5 and various lengths depending of the patient, of course. So the technique were like this. So that's a summary of what we were using, and in some case, so we discussed about the location. We didn't, most of them we didn't do KIFO at the same time, but for 2 patients, the operator was doing KIFO at the time. So various implants, more or less 5.5. We use this French cement F20. That's something we could discuss later. With the injection kit system was provided for the F20. In terms of cement, we use more or less what we observed in standard vertebroplasty or kyphoplasty. It's between around 4 to 5 milliliters per level. Duration was depending on the learning curve, and the first cases were we also had some selection criteria among the. We obviously improve our selection. And so that's why the time of the duration of the procedure was longer at the beginning and then shorter at the end. And the hospitalization stay was almost very short, except for one patient. But I think I'm going to show you the case. So, in terms of technical results, the procedure was technically feasible in all patients. No one was excluded. The median procedure time was almost 1 hour. The volume of PMMA was 5 milliliters, which is kind of standard. And we also record in that study how easy was and difficult was the steps, procedural steps to implant the device. And I'm going to show you. So, but it was more or less in 90% very easy. And we only observed 10%, 13 over 128 steps of issues. And this was mainly related to the cement itself. That's why the F20 we used as probably because we were not very familiar with that cement at that time. So that's a summary of what we were using and the steps. And so we studied the guide wire implantation, dilatator tube, etc. Everything you know about the procedural steps. And it was mainly easy and very easy for most of the patients, but sometimes it was difficult. We had some report for the tube implantation, but you know we have that's something with a learning curve. We improve the implantation. So that's a case. But probably tonight we are going to see several cases. So after selecting the adequate device based on the size of the pedicles, we implanted devices. That's another one, and that's the one who stayed very long, not because of the procedure itself, because it went very well, except that it was a plastic bond, so it was quite hard to drill and place the device. But finally, we had to place this adequately. No, the patient stayed because of the course of the disease and was not able to leave the hospital. And a very unfortunate reason is because he gets the COVID at the hospital and stay at the hospital for this reason. That's another case with the procedural steps to place the device, but that was an osteoporotic patient. Quite easy in that case. That's the case I show you just before, the blastic lesion we treated with a V-STRUT in L1, and we had some issue at that time. So adverse events. So we record all the adverse events, and only minor adverse events were reported. And I'm going to describe them. We didn't observe several complications. So that's what we record in terms of adverse events. What is very interesting in our patient is we didn't observe adjacent fracture over the follow-up, which is not surprising because it's very low number of patients included. But it's still something that we didn't observe anything, and that's already a start. And also we observe some improvement in the pain after treatment over the course, and mainly at 2 months and 6 months. Unfortunately, we have with the patient, we had a patient with cancer mainly. That means the location in the spine was not, for some of them were not related to the cancer itself, but osteoporosis. But a lot of them, not a lot of them, half of them died during the follow-up. Just to go back to the occurrence of cement leakage and adjacent fracture, in fact, if we compare to the literature to spine jack or a KIFO or Kiva, etc., in fact, the numbers are quite similar for cement leakage. and we didn't observe any adjacent fracture after. But obviously the number is different. One thing that we could report is if you already used V-STRUT, try to not remove the V-STRUT by forgetting to dislog the device of the instrumentation, because it will come back with the cement. It's nearly impossible to get it back. So that case illustrates this is fact when the instrumentation was removed, the V-STRUT came with this. So that's the issue we observed. The only issue, it was nothing happened to the patient. He was not complaining about anything, but that's something we should avoid. So just the outcomes was the hospital stay was 2 days. We mainly did this as inpatient. The disability improved over time, but this patient had mainly cancer, so there are other comorbidities, and it was not very helpful. But I mean, we still saw some improvement. So that's the pain. So we observe a significant decrease in pain. That's a good thing. That the outcomes, so I already mentioned this, and most of them were discharged, but some of the patients died after due to the course of the disease. So key messages for this very small prospective study. So we didn't observe serious safety issue with the device, only cement leakage and no pedicle fracture or adjacent fracture. So we remain in the standard of the literature. We had the issue with the cement, so that's something we improve over the time. And I think now there is, I think we are managing better than what we did before. That's already something. And the implantation was quite easy, and we obtained some effect with the reduction in pain and improvement in function. So that was the goal of this treatment. So that's great. So the limits of this study was very small size. It was in France. We were starting with the implantation of the device. Very short follow-up. We had patients who died during the follow-up. So that's an issue to record and monitor all the parameters. We had issue with the COVID. That's seriously impacting the inclusion and the follow-up of the patient. And we didn't compare to any other techniques. So in conclusion of this study, the implantation of V-STRUT appears feasible and safe. We obviously need larger and comparative evaluation. And so I think I would, as first implanter, I would be very happy and excited to see the results of the procedure performed here in the US. And that it's very promising. Thank you.
So I decided to change based on discussions with colleagues and musings at meetings where we were frustrated and wondering why we kept on having these adjacent fractures or refractures at the levels that we're treating. And I was talking to a colleague from Europe, Alessandro Cianfoni, who published a lot recently on the SAFE technique and his similar frustrations in these large lytic vertebrae, or these vertebrae that have fractures at the base of the pedicles. And it made a lot of sense to try and find a system that gave reconstruction of the anterior middle column, but also the posterior column, which is missing from everything that we do. We don't have percutaneous screws in the US. We don't have open screw systems that the surgeons do. So I was looking around the literature and I came across V-STRUT and the system that was being used in fractured neck of femurs. And it made a huge amount of sense. So I actually reached out to Cecile some time ago to look into the device. And that's why we brought it on at Mount Sinai. And we're going to talk a little bit more about what we've done with the device, but also how we're moving forwards with a clinical trial as well. So we'll talk a bit about the biomechanics and cases, or specifically a case with a description of how we do the procedure, and then the study, which is called Reconstruct. So everybody knows about the device. Most of us have probably done the training, but it's indicated from T9 to L5. It's indicated to be used with PMMA, and it's a 510K device, as you said, based on predicates, and that was Kiva. It's a peak polymer, so it's not metal. It doesn't behave like titanium. It has the ability to absorb flex and stress, which is important, and it comes into some of the reasons why I think hopefully it's going to prove useful in preventing adjacent level fractures and restoring some normal momentum and movement to the spine in these osteoporotic patients. But essentially, it's indicated at this stage for Gennett fractures that are grades 1 and 2, so not severely compressed, not the vertebraplanar fractures, but ones that have superior or inferior end plate deformity, leading to less than 50% of fracturing at the level. Sorry, we're jumping across a little bit. So the biomechanical principle, it's a peak polymer. It's closer to normal bone in terms of its strength and flex than titanium is. It gives pedicle anchorage, and the idea is to share load between anterior middle column and posterior column. And again, the idea is for this 360-degree reconstruction, which is more physiological, it's anatomic, and it's what I think we should be aiming more for in the treatment of these patients. And why is that important with aging? Normal spine, the distribution of loading is roughly 50-50 or 60% anteriorly, 40% posteriorly. But with age and loss of trabecular mass and more kyphosis, you get a decrease in the posterior loading of the spine and an increase going through the anterior column, which I think comes to a bit of a debate and discussion as to why these patients fracture adjacent levels after treatment, especially if they have significant deformity from their kyphosis. And the intent is for this device to rebalance that load to the posterior column. So Cecile and Dr. Hambly and myself have just recently published a paper which has only just been accepted by Clinical Biomechanics, I think. It's not available on PubMed yet, but hopefully it will be soon, looking at a finite element study to quantify the redistribution of force through the vertebrae. And this is the findings. So as we said, peak material reduces the stress in the treated and adjacent vertebrae. And that was the finding from this experimental model, when part of the applied stress is actually transferred to the implant and offloaded from the adjacent vertebrae above, but also the vertebrae in which it's been implanted. And when you compare that to things like titanium, and I'm not trying to pick on SpineJack because I've used SpineJack and I still use SpineJack. I think it's a good device, but I don't think it's quite the answer in solving the problems. I think it's a good device for a specific kind of fracture, but I don't think it's the only device that we really should be looking for, or the momentum in terms of device development should stop there. And obviously, titanium is far, far harder than healthy bone. So the load stress is transferred to the upper vertebrae. And that is one thought of why you get adjacent level fractures, at least from an experimental model. If you look above here, just on the heat map, the center pane is the V-STRUT with the peak implant. You look at the color map or the heat map, the adjacent vertebrae, comparing it to a titanium pin versus a normal vertebrae. And there's, a fairly clear difference. Going to move on. So what's the experience so far in the United States? And this may have changed recently. There might have been 1 or 2 more cases, but there's somewhere in the low 20s worth of cases, most female, which we expect, as opposed to Francois' case experience in France. It's vastly more commonly to be osteoporotic rather than malignant. I think that there's probably a little bit of a reticence, at least initially in the United States, to put an implant into a patient with cancer. So that probably explains why there's been a slow uptick on that. But specifically at Mount Sinai, I think we started using the device in January of last year, or February as our first case. We've done 7 procedures, and we've been really quite cautious in who we're using them in, making sure that they're on target, on label in terms of fracture classification, but that there's pretty clear space and size within the pedicles for access. And if it's borderline, then we're not using it. And to be honest, that's probably being a little bit conservative, again, based on our experience from using things with like SpineJack with larger access devices. So far, we haven't had any procedural complications. We have experienced some perioperative discomfort at the soft tissue access sites in the back, one with expected things that you're going to get, which is going to be slightly more, obviously, than if you're just using an 11-gauge jam sheety on one side. We've had 2 patients with disc cement leakage. And with this device, if there is a cleft or a fracture going to the end plate, then it is going to the cement's going to travel down the path of least resistance. So it takes some technique in avoiding that. We've had, of the 7, 1 adjacent level fracture, and that was in a patient that had cement leakage, where the cement leakage into the disc was more anterior, so in the anterior half of the disc, and morphologically it wasn't sessile, it was more of a pointed aspect of cement going up and coming close to contacting the inferior plate, and that patient went on to fracture that level. And in retrospect, most of the time in my patients, if I think that they're a high risk of adjacent level fracture because of that die punch effect, I'll usually go ahead and cement that level just prophylactically. And that's something that I think we should have done in that patient. This is the one case that I want to show, and it goes through a little bit of the technique as well. So it's standard kind of fracture. This is an L1, I think. It's an A1 junctional level fracture, again, at grade 2, just over 25%. There's no pedicle involvement. There's no retropulsion. The canal's nice and normal in length. Patient had quite severe pain. It was a 4-week-old fracture, but the patient presented to the emergency department and needed to be admitted for pain control. So in those patients, if I feel like we have a really good system set up through the emergency department, if a patient's presenting with a compression fracture and they're presenting for pain control or tolerance of pain failure as an outpatient with narcotics or simple analgesia, then that's failure of conservative therapy. And those patients, in my experience, typically bounce back. And if you take them and follow them up in clinic, then they usually will come back anywhere between 2 weeks to 3 months later. And if it's 3 months later, often their fractures are now quite comminuted and collapsed and much, much harder to fix. So we've tried to circumvent that by early intervention and early follow-up. Just the basic early films, straight APs and laterals. You can see the wedge. Okay, so this is how I typically do the procedure, similar to spine jack. So I do it down the pedicle view. I measure the pedicles. I take a jam sheety and take it down the pedicle to the pedicular somatic junction, swap over for a K-wire, and then drill the holes, upsize the drill holes, and then measure the device, insert the device over the K-wire, and then cement. Just repeat the same process. I use a cross-targeting technique down the pedicle to try and make sure that the devices are going to meet in the midline, similar to using a transpedicular ablation technique for tumor and as well. And this is one of the patients where there was cement. So, sessile, small volume of cement, not getting anywhere near the disc, not anterior, so we decided not to cement. And then the final pictures. She did well. She ended up with good pain relief when we followed her up at day 14, so down from 8 to 4. Unfortunately, since then, she hasn't come back to see us yet. So, and that was, I think her case was performed last October. So moving on. This is the clinical study that we've partnered with High Prevention for out of Mount Sinai. It's called V-STRUT. It's a prospective pilot study based in the United States, focusing on osteoporotic fractures primarily, but you can enroll malignant ones. It's 4 sites, of which we have 4 selected centers, Mount Sinai being one. We're the only active enroller at the moment. The other ones are going through VAC process and IRB setup. And we have 2 patients enrolled. The inclusion criteria is standard inclusion criteria that you'd expect for most trials, and these have been largely piggybacked off the SACOS study with the intent to hopefully enroll quickly, get some signal from the data, and then move on to a pivotal study and potentially use pre-existing data as a comparison arm. And you could do that with Markov modeling and hopefully avoid something like an RCT. These are the included types of fractures that we're keeping. So A1s, A2s with sagittal and coronal clefts, and partial burst fractures, A31s. At this stage at Sinai, we haven't done any burst fractures. We haven't had any cleft fractures. They've all been A11s to 13s. And this is the standard of follow-up that we're keeping to the study, and this more or less mimics what we do in clinical practice at Mount Sinai, and you can see that by all the standard of care. So CT scans at 6 months, CT scans at the treatment date, usually by a flat panel or cone beam CT, VASs, Westry, EQ5D, Roland Morris, and sequential imaging follow-up with scoliotic series. So we're trying to be as complete as possible and bounce from that into a larger pivotal study with some luck. I'll leave it at that and pass on to the next speaker.
So Francois and Reed and Cecile, thank you so much for allowing me to be a part of this. My name is Dr. Neil Curran. I'm an interventional radiologist at VIS in Siouxland. Siouxland is an area in the Midwest spanning over across 3 states, South Dakota, Nebraska, and Iowa. I've been doing vertebral augmentation for about 7 years, and probably an N of somewhere around 300 to 400. I really lost count, but obviously I'm very passionate about intervention in this arena, given that there's a lot of players, whether it be neurosurgeons, interventional radiologists, or pain specialists performing these. And what I simply was attracted to is this is a elegant evolution of what already exists. Most of us, as Reed was saying, who perform vertebral augmentation will find this very similar to SpineJack or any other device that's out there. But I think what the future holds is that stabilization that we're all so curious to know clinically. Will it make a difference? Will it reduce adjacent level fracture? And in my anecdotal experience of 3 cases, I'm seeing promising results. You have to understand, not being at an academic institution, I'm limited to sometimes where the patient might get their imaging from. I'm limited, by maybe low quality MRI per se. And I'm also limited as far as the knowledge of the referring population there. So I receive fractures sometimes very late. They're partially healed. Sometimes there's more wedge deformity than I would like. And you can see the progression if there's 2 MRIs back to back in a month that the primary care had ordered. It kind of leaves us in a place where we haven't optimized that chain of command like you would see at Mount Sinai or any big institution where there's a fracture and the appropriate people are called immediately. So I just think my participation in this talk is more for the folks out there who may not be at the academic level, that you should definitely have your eye on this as an option, because it's very doable if you do vertebral augmentation, and the results so far have been very good. So I just have 3 cases, and I don't have much written on the screen as far as words go, but there are a lot of pictures, and I would hope at this point Cecile can help field questions during these cases, because I would like an open discussion. I'm sure a lot of you have experience in this field and can offer advice or comments on what you're seeing here. So this was the first case we did back in October. It was a male, which is kind of the minority of the patients I treat. But then again, he did suffer a fall. I did not have a DEXA scan on him, but this fracture had been kind of brewing for over a month, and he failed conservative therapy, and came to me. Actually, a neurosurgeon sent him to me, and I considered just doing vertebral augmentation. The deformity there was not too wedged where I even considered using something like SpineJack. I was just going to do a kyphoplasty. But his pedicle size were adequate, and it was a good case to test the product out. And so basically, again, I'm not going to belabor the procedural part of this, but this was done in my office. I have an office-based lab. We have a Siemens floor-mounted unit. It does have DynaCT, so it has cone beam CT. So if at any point, if we ever felt that we needed to check where we were, we could, and that's a luxury. Of course, any of you out there who don't have that on your fluoroscopy units, it's not necessary, but if you do have it and just haven't used it, this is a great case to do that. Even in the planning stages, if you're looking at the MRI and you're saying this is going to be a great case for this, and you put the patient on the table and you can't get that perfect lateral, and you just, the visualization, maybe the patient's obese and you can't really see very well, doing a cone beam CT can have you just measure those pedicles. And at that point, if you feel they're not large enough to accommodate the device, you can just go ahead and do traditional kyphoplasty. So in this case in particular, the cement, we did use Stryker cement, Vertiplex HV, and we did not get a crossfill. And, I'm obsessive about that, maybe a little too much, but it's one of those things. Are we treating the patient or are we treating the picture? And at the end of the day, we were very happy that there was an extravasation. We did get maybe a little bit of some cement in the pedicle itself, but we weren't too worried about that. You can see that right over here on the AP. And he had a follow-up. He did great clinically, by the way. So he came back about 3 or 4 weeks later in clinic. He did wonderful. He was pain-free, and he was very, very happy. This gentleman took another fall and had pain. And of course, it was a trigger reaction to get an MRI by his primary, given that he had already fractured once. And the picture on your left is midline. And as you can see, the original fracture over there at L4, there's still, this is a stir image showing edema in that mid portion. And you can see the new fracture there at L1. If you look laterally, you can see the cement fill in our treated region, and then you can see his new fracture there. Now remember, when he followed up after his original treatment, he was pain-free. So all his new pain, and on examination, his pain is in the higher thoracolumbar region. But it was nice to get the MRI, because here we are doing our first case, and now we have an MRI follow-up. And one thing that's really nice as a radiologist, and I'm sure for any neurosurgeon out there who's looking at MRIs, this is the actual peak polymer in the pedicles, and you can tell it has no blooming artifact. There's no gradient artifact from metal. So it's just something to think about. You know, the device itself doesn't cause any artifact on future MRIs, which is really, really nice. Over here in the middle, you can see our device through the pedicle. Second case, and let's mention also that on this first case, that adjacent level fracture, you can tell these L5 and L3 are intact, and he in fact fractured L1. So with a fall, his L3 and L5 appear to have been protected. So for our second case here, it was a 63-year-old female. She has maybe, mild to moderate biconcave compression of L3. This was a very straightforward case. One thing I did notice is, because of her lordosis and just the way I could get into her pedicle safely, I wasn't able to come as parallel as I could to that end plate. But at the end of the day, if we look at the biomechanics of what we're trying to achieve here, I mean, we're just transmitting those forces through the vertebral body posteriorly. And so even with this access, I was still happy to proceed, and I felt it was safe to do so. In here, and I think, Reed, you probably were looking at this and saying, you didn't get those exactly midline as mine, but I did notice that too. And there is a learning curve with the device. But at the end of the day, this patient did exceptionally well, and clinically, she did great. Our third case over here, this is one I would kind of wonder if anyone in the audience has commentary on. This is a very advanced fracture over here at T11, I believe. I'm sorry, T12. And if you look right above at the anterior inferior margin of T11, there is a little edema forming. And this is one where I said, if I'm going to treat T12, I'm going to treat T11 as well, because that's going to fracture eventually. I also treated L3. So I did a 3-level case. And which device out there would people use, let's say, for any of these levels, for 11, 12, and 3? Just to have some audience participation here, if anyone's, wants to take any comments out there on what you would use for this. Okay, well, if you have it in your head of what you think, what I did was I did a traditional kyphoplasty at T11. I did a spine jack at T12, and you can see one of the skis is popping out that lower margin of the inferior end plate. But she did fine, and I did a kyphoplasty at L3 as well, and she did very good. 2 weeks later, she fell out of her wheelchair at her nursing home, and this lady's bones were like soft as butter. I mean, she is osteoporotic, and this was the true test. When she came back with new back pain, and we MR'd her, and these are the type of images we get. They're low magnet, 1 Tesla images. They're not that great, but she clearly has a new fracture underneath the spine jack at L1, and that's what we had to treat. So we measured her pedicles up, and luckily we did have a CT from about 4 years ago that I used as a reference because the MRI quality wasn't too great. I would say the resolution of that is probably within a millimeter, but I wasn't confident to say that her pedicles were exactly that. So luckily she had a CT and it looked adequate to go ahead and proceed. So now we have a picture with T11 with our kyphoplasty, T12 with our spine jack, and L1 with a V-strut. And cement distribution was very nice. I was very happy with the way these deployed. By the time we got to the third case, I say the procedure time was probably around 35 to 40 minutes, maybe 40 minutes, I think, once we got all our ducks in a row. So that's my takeaway coming from a community doctor who does high volume vertebral augmentation, is that I believe this device is useful for stabilization over height restoration. And I think what we need to know is, looking forward with the studies that are coming out, is that stabilization going to have a better clinical effect in the long run? I know that's height restoration is very attractive from an imaging standpoint, and it looks great. And of course, restoring some kyphotic deformity in patients, I'm sure it has its mechanical benefits. But this is an elegant evolution of a procedure that already works. So I'm excited to be using it, and I'm excited to present these 3 cases to you. Thanks for your time.
Thank you very much. Thank you to all of you. So does someone have a question to ask to our speakers? Feel free to unmute your microphone and ask your question.
You can also type your question too if you're camera shy.
It's not really a question, it's just a comment. I think it's really apt and well described that you talk about evolution. There's the wonderful thing about interventional radiology and interventional neuro and the field is that it is really fast moving, and it does lend itself to these really fantastic developments and changes in device. Again, like I do a number of these cases, and probably in the order of maybe about 150 a year in augmentation. And it's not really looking at the literature. It's more just anecdotally picking up on what happens to these patients when they go away and come back when you do a lot of them. And you see that even though, standard kyphoplasty is super powerful, it's a really powerful technique. Spine jack is a powerful technique for the right kind of fractures. There's a large percentage of patients and group of patients that do go on and fail and do go on and fracture. And it's obviously very, very multifactorial. But like you said, one of the evolutionary points is trying to have more of a bricks and mortar kind of approach to the three columns of the spine. So I think what you said about the evolution and hopeful potential is really apt. And they're great cases, really great cases.
Thank you.
Thanks to all the speakers for some great talks. Just had a question about cement distribution with the device. With there being perforations all along the length of the peak strut, presumably when you inject, you're having the distribution be fairly even right from the get-go. So as opposed to injecting and having the vertebra fill with cement, anteriorly and then come back over time, presumably you're immediately getting filling in a distribution of the anterior and middle column. I guess I just want to check if that is in fact the case. And then secondly, when you talk about the distribution of stresses, do you think that's entirely attributable to the peak implant, or do you think it also may have something to do with the fact that you've got a more even distribution of the cement?
I think in terms of the engineering principles and the distribution of force, it'd probably be best for Cecile, you to answer that question, because the study from my memory was essentially just using the device. There was no cement added to the FEA study or the FE study.
Yes. In the study we have published and the initial finite element analysis we had conducted, it was the implant alone. and we were able to show that the implant made of PIC is able to absorb part of the stress received on the vertebral body. But we have conducted more finite element analysis that should be published soon, where we combine the PIC implant with the cement, and we come to the same result. So the PIC implant is able to absorb part of the stress received on the vertebral body. But in terms of quantity of cement, what we have simulated, it's quantity of cement more similar to a vertebroplasty. So it's not a big quantity of cement. It's a quantity of cement that you need to, so the cement is injected through the implant, goes outside the implant, but it's really less than a big quantity of cement that you will inject if you do a kyphoplasty or if you do a spine jack and if you create a big cavity.
Thanks.
Now, in terms of this cement distribution, Gerard, my experience, and again, we've only done 7 out of the volume that we do. The cement, you can somewhat, I guess, dictate a little bit how many of the perforations the cement goes through by the kind of pusher that you're using, and we're using just the vertiport pushers from Stryker. And I think those more or less come close to, or if not, maybe 1 or 2 perforations down the device. So it will come out a little bit further to start with, but where the cement goes is somewhat dictated by, you know, the viscosity of the cement, where your devices are in reference to the fracture planes and how close they are to the disc and that kind of stuff.
Yeah, the recommendation for the injection of the cement is to start from the middle of the vertebral body in order you have an idea. So middle, I mean between the anterior and posterior wall, in order you have an idea of how easy the cement can be injected in the vertebral body, because sometimes the bone is not homogeneous, and you really don't know exactly where the cement will go. So we recommend that you start in the middle between anterior and posterior wall. And if you believe that you need to be more anteriorly, go more anteriorly because you don't have enough bone cement anteriorly, you can push your bone filler more anteriorly and inject from the anterior wall from the posterior wall. But the recommendation is start in the middle to limit the risk of cement leakage.
Thank you.
And one more comment about that is on the 2 of my 3 cases, you know, I did have some cement fill the device into the particular portion of the device, which is not intended. The device was designed to have the cement purely within the vertebral body and not come into the device on the way out. Just when you're doing traditional kyphoplasty or vertebroplasty, you can build up a considerable amount of pressure within that vertebral body. And when you take your pusher out, or you know, you're pulling your introducer out, you can have that so-called tail of cement follow you out the pedicle, which is always looks bad on imaging, but it really doesn't have any clinical sequelae. So I'm still trying to, you know, figure out exactly how to prevent that from happening with using this device, even though I don't think it's going to make much of a difference in the long run.
Any other question? Dr. Palapos, you don't have any question?
Sorry, I had to exit and come back again because I lost sound, but I hear you now. Yeah, it's just, you know, I always wondered about this, about the adjacent level fracture, namely by placing the cement in one vertebra, then the stress is transferred to the adjacent one, and that fractures also, you know, suffers fracture. I understand if there is you know, there is cement, just accidentally, and cement enters the intervening disc, then I understand that the stress or whatever, the mechanical load would be transferred. But how does it transfer through an intact, if the disc is intact? I mean, the only way it could transfer through the posterior elements, right? Because the disc in between acts as a cushion.
Yeah, so the disc will continue to act as a disc, but the quality of the bone makes that sometimes you will have a adjacent fracture. So if you transfer the stress on the anterior column to the posterior column, you reduce the overall stress in the anterior column and you delay, maybe you don't prevent fully, but you can delay the adjacent fracture. So delay means in the literature, about 25% of adjacent fracture at 6 months using kyphoplasty, according to the recent study. So delay could be that the adjacent fracture will happen at 12 or 18 months, and it's a big win for the patient.
Mm-hmm. You did show a slide there.
Yes, Dr. DeLacy showed a slide of the finite element analysis we had conducted.
That's right. That's right. Yeah. How gets transferred? Yeah.
Yeah, and as Dr. DeLacy said, the article has been published, so it will be available soon. It was in press, so I will transfer it to everybody soon.
Okay, thank you. So let's say you mentioned, and Dr. DeLacy mentioned, and I think it was you who mentioned that if you see that for whatever reason you suspect that a adjacent level fracture could occur, then you treat the adjacent vertebra, shall we say, prophylactically. And if that is the case, would you use a V-STRUT, or you would just go? Would you just use a more conventional augmentation?
The answer to that is I really don't know. You know, I don't think there's enough data to be saying what the perfect kind of method for treating them is. That's why we're doing the pilot study, and hopefully it does come to prove that by the natural history of osteoporotic fractures or other studies of kyphoplasty, and that the adjacent levels will go down. At the moment, if you know, I see a patient and I think that they're going to fracture the adjacent level, or I think that they're going to fracture an intervening level between two vertebrae, then I'll typically cement them. But at this stage, I'm just doing a standard vertebroplasty for that.
A semi-question, semi-comment on that topic. Am I correct in saying if you do that, you shouldn't bill for that level because it's you're not treating a fracture? Is that correct? Yeah,
you can't bill for that.
Yeah.
So unless there's evidence of fracture, but at the end of the day, and this is one of the things that you know, I'm Australian. I trained in Australia. I've been in New York for about 9 or 10 years, and I certainly struggle with, in terms of the whole billing scheme and the whole nature of that and the restrictions put on you by the hospital. Like at the end of the day, you know this patient has a super high chance of coming back and they're going to be in pain again, and they may not follow up, and they may not follow up for a month or two, in which case that fracture is going to be much harder to fix. So do you do the right thing for the billers, or do you do the right thing for the patient? And I just typically do what I think is right in the moment.
Yeah, no, I agree with that. I just don't want to have to experience a Medicare whatever case or yeah. Yeah, no, that.
Yes, Dr. Ajis, please, you can open your microphone.
Sure. Thank you, everybody who spoke, and thank you, Cecile, as well. Very, very good talks for everybody. My question is more for Dr. Corona, because I am in an outpatient, non-academic setting as well. I kind of wanted to hear, you know, your experience based on really how you incorporated this into your practice, from both kind of like a procurement standpoint and a like a financial standpoint and billing and kind of everything that goes into it, because I think I would be in a similar situation.
Sure. So just really to be as brief as possible, but to answer your question is I provide interventional radiology services at a level 2 trauma center here in Sioux City. I also provide services at another adjacent community hospital. And I have an office where I do most of my work. But at the end of the day, the case that I did show that I did in my office, that was something because I was having trouble getting the product approved to be on contract to go ahead and use it. We still bill the same as a vertebral augmentation in the office setting, and we just paid for the device, whatever it costed. At the end of the day, it was kind of, I was benefiting a lot from getting my hands on the device and getting familiar with it. And once I understood the power it has in trauma or in cancer, I just presented it to the hospital. I said, this is another tool. It needs to be in our toolbox. It needs to be on the shelf, just like spine jack or anything else. So we're at the process of still getting that approved in our hospital, but that's primarily where I would be using it. So that's as far as the procurement of the device and getting it on the shelf and the billing. Getting patients for this, I mean, again, I'm getting a lot of referrals from primary care and family medicine and some ER physicians and some neurosurgeons and some orthopedic surgeons. The cancer folks haven't really caught on to this. I'm meaning to, I spend a lot of my time going out there, and as you probably do too, building a business for yourself, a practice. And so it's going to be slow, but I think that this has a lot of potential in the cancer, especially in lytic lesions and in multiple myeloma. I mean, these patients fracture one after the other, and it kind of actually starts to look odd when they have more kyphoplasty levels than they do unkyphoplasty levels. And, it raises your eyebrow. It's like, what are we doing? But this is hopefully going to change that.
Thank you.
Any other question? Dr. Massari, do you have question? I know you are more interested by the indication in oncology.
Yeah, that's obviously the main component for me. We have a large practice of oncology patients. So for me, the interest of redistribute the load on the 3 different columns, and especially when there is a pedicle involvement, try to use this device also to stabilize, give more support is definitely extremely appealing. So that's the main interest. Unfortunately, with the FDA, we cannot use some devices that I could use in Europe. So all this stent, balloon mounted stent, all these options that are not available now. So this is definitely one device is promising, and definitely something that I'm, thinking that can be extremely useful in, especially in oncologic practice.
Dr. Corona, as I remember, you treat a case with a pedicular involvement. Can you describe how it went and if you had difficulties doing this case?
Sure. I'm going to share my screen one more time. I think I have the image. But, honestly, we saw edema in the pedicle, and I believe there was a low T1 signal across that pedicle as well. And yeah, I don't have the picture. I apologize. But anyways, again, there was a clear fracture across the pedicle. It was perpendicular to the pedicle, and we had no problem with access. We had no problem. The patient did fine clinically. Again, I think you have to be very careful and just not go full cowboy on these. If there's a fractured pedicle and there's significant disruption, I mean, that's not the indication for it. But from a stabilization standpoint, I mean, I think that it served a great purpose in that patient in particular.
Yes, indeed. At the moment, it's not part of the indication. It's a contraindication. And the reason is because we don't have clinical data that we can show to the FDA in order to get the indication approved. But we will. Any more questions?
I have a quick one. I think I brought this up before. So we have all these different ways of treating these fractures. The group, where does V-STRUT fit into? Well, practically, how do you guys decide? And I'm going to use a V-STRUT on this patient, and I'm going to use a spine jack on another one, or just balloon plasty or no balloon, just cavity, like a merit system where you use a osteotome?
I think if there's, for me personally, if there's a wedge deformity that's greater than 50%, 60%, you know, I might be a little bit more prone to try to restore some height, depending on where it is in the spine, obviously. You know, having kyphosis can really put some strain in the mid-thoracic levels or low thoracic levels of the adjacent levels. So at that point, I would like to do some height restoration. But if somebody has a nice vertebral body that has a lot of edema, microfractures throughout, maybe there's a cleft, maybe there's not, and they have good sized pedicles, I think that this is basically as good as doing a traditional kyphoplasty on those patients. So it would be quite a few, as long as there's, in my opinion, if the height is preserved, it's a good device to use in that instance.
Mm-hmm.
Yeah, I think very similar to Neil. So those Gannon grade 1s and grade 2s up to 50% height loss, not overly comminuted fractures at this stage. And for fractures where there's a lot of vertebral necrosis or big clefts, big gaps and spaces, I typically wouldn't use it or don't use it at this stage. I still just use like a curved cement delivery cannula and maybe a balloon or a curette, but that's about it. But yeah, I think, you know, I think what you're touching on is trying to develop a bit more of a bespoke, evidence-based way to approach fracture management and fracture treatment, which I think is the right way to go and where we should be moving to. And it's more practical and probably will have better outcomes in the long run for patients.
I kind of wonder if and maybe this is like controversial, but you know, based on things like rebar principle, should we not be trying to reinforce with concrete having you know, low tensile strength? It seems to make sense to use an implant as often as possible for fractures, just in terms of distribution of forces and in terms of maintenance of loads, just overall. I mean, I know it's an additional expense every time, but in terms of biomechanical principles, it seems to make sense to use it as often as possible.
It's a good point. Maybe. I guess the answer is maybe. Like, I don't know. It all comes with clinical data. Just as an aside, when I was talking about the clinical trial and trying to find a name for it, I came up with rebar because I thought it was awesome and it's a great name for a clinical trial, but they stole it in Europe for something else already.
Okay. Thank you very much. Thank you all for attending this first peer review. Thank you for the speaker for the presentation, and thank you for the attendees. And I hope to see you soon in the OR. Thank you very
That
much.
was very useful. Appreciate it. Thank you.
Thanks.
you.
Thank you.
Great,
Bye.
great
Thank you very much.
Thank you.
Nice.
Thank you. Bye, guys.
Bye.